Okay, so welcome everybody. It's good to see you. Um, for I think it's our 31st conversation on the future of work. And I'd like to just quickly acknowledge the National Science Foundation for partially funding this effort. And it's a recorded conversation. And if you have questions, then please put them in the chat and or it will be moderating those. So I'd like to welcome Helena Mentis. Helena is a colleague and also an associate professor in the Department of Information Systems at the University of Maryland, Baltimore County. And she is also the director of the Bodies in Motion Lab. And she's also the president of ACM Sakai. So welcome, Helena. It's very nice to have you. And I wanted to start out by talking about your work in telemedicine. And by the way, what a timely topic, isn't it? I don't know if everybody else has experienced this, but we've certainly taken our share of telemedicine meetings and been very grateful for the opportunity. And so in 2020, you had a CHI paper entitled Remotely Shaping the View of Surgical Telementoring, if I'm getting this right. So can you tell us more about what the problem is that you addressed here? So how are surgical teams mentored in the first place, and where does telemedicine come in? And then there's also this term shaping the view. So I was wondering if you could tell us more about that.
Well, thank you all for having me. I really appreciate the opportunity to speak about kind of one of my favorite topics that I've been working on for the past probably 5 years, and finally people want to talk about it. And telemedicine obviously has been around for a really long time, but I think, like, as most of us are familiar, it just wasn't taking off. And so this has actually been one of those fields that has been on sort of the periphery of medicine for a while. And I got involved in it based on some work that I was doing with surgeons a number of years ago, doing imaging interaction in the operating room. And one of the things that I learned from the surgeons that I was working with is the problem with mentoring surgeons in new techniques and making sure that particularly those surgeons that are in more remote areas of the United States or more remote areas of the world have the opportunity to have the same type of education experiences as those who are in the US. And you can hear my daughter screaming in the background.
Yeah, the kids in the background is a pretty common thing.
It is the new world. And
it is.
I will actually
it's the future of work.
So one of the things that a number of surgeons that I was working with were trying to do was trying to implement telementoring. So the idea behind that was giving surgeons the opportunity to maybe pick up some skills in a surgical setting, usually going to a sim center, but then having somebody who they trust and who is one of their mentors to take them to take those skills back to their home operating room. So it was quite a common occurrence that you would have surgeons go and pick up a new technique, for instance, in laparoscopic surgery in particular, which is much more different than opening up the body and seeing the body. It's instead you're seeing it on images, you're using tiny little cameras to insert, and then you're using long surgical tools to do the work. So what would happen is that surgeons would learn these techniques, but then they wouldn't feel comfortable being able to continue doing them and practicing them in their own operating room without having, a secondary person nearby. So this was like a great opportunity to bring in telemedicine tools and to have somebody sort of look over their shoulder and say, that looks good. And don't forget, you need to do this. And yep, keep doing what you're doing, giving that sense of confidence. And all of this was really about just being able to spread the new techniques in surgery. Surgery is a constantly evolving field of medicine. And it's still in a lot of ways the Wild West, where there's always new techniques and tools being devised in order to make surgery safer and more cost effective as well. For instance, laparoscopic surgery can be done on an outpatient basis. You come in first thing in the morning, you could be out with your gallbladder removed at the end of the day. And you can heal much faster as a patient. So there's lots of reasons why this was in the works. So so because I got involved in that, I was really interested from a CSTW perspective, which is my home discipline. What have we already learned about how people communicate through this world, and how can we build better tools? Because there was a lot of, well, can't we just use Skype for this? This is before Zoom took over everything. A lot of people were not really sure what were the opportunities, and there were a few companies building some tools, but they were very, very expensive. So the shaping of the view perspective came out of work that I actually had done with surgical teleconsulting with the Google Glass, when the Google Glass was all the rage. And at that time, we were recording videos and sending them to another surgeon to look over. And one of the things that I talked about in some of my early work on that is how what is recorded and how it's narrated, and even like how you might move your head in with the Google Glass or point to something, that's all very much defined by the person who's capturing the video. It's not really defined by the person who ultimately is watching the video and has to make a decision based on the video that's captured for them. So the work that you referred to at CHI this past year was work that we were able to do with a system called Visitor One. And it is a live telemedicine system for the operating room to be able to do things like telementoring. And what I wanted to see is what happens when you give the opportunity to the remote surgeon, the person who has to watch this transferred video, the opportunity to weigh in on what the video should show. You know, I need you to move over here, for instance, or can you zoom in? And that's what I'm calling shaping the view, because a view of the work area is really important for the two collaborators to agree upon. It can't be one person defining this is how we're going to look at it. It's almost more of a co-construction of the work area that they need to sort of agree upon and continue to negotiate as the work evolves. And that allows for maximum collaboration at a distance, or even when they're just co-located, as some of my really early work was looking at. So this has been a great time. That work was done before we went into COVID. And to be honest, what's really important is it really obviously blew up because of COVID. And what I think is one of the most interesting things is that we always talked about how telementoring was for, say, the rural surgeon or the surgeon in India to learn new skills. You know, we'd always talk about those that were disadvantaged. But what happened after that to a lot of surgeons though is they said, well, now we're all using telementoring because nobody's driving anywhere. And I can't even go to the next state over without then having to quarantine myself and not be able to do my surgeries the next morning. So now they're all just trying to find the opportunity to do this, this telementoring situation. And one of my colleagues, I even have pictures of him sitting in his closet at 5 o'clock in the morning, trying not to wake up his family on the floor, watching on his computer the videos directly into the operating room. So we're all sitting in very weird spaces, doing a lot of very weird work through our computers right now.
Well, it's a nice opportunity to take advantage of the work that you've already done for all of us. So I guess regarding the CHI 2020 paper, so what were the main findings? Is it basically first of all, this need to collaborate in figuring out which way to look at things, positioning things?
Yeah, so one of the things that I wanted to see is if what I had learned from being a recorded video, we'll just ignore her. She thinks this is hilarious. Prior work, which is recorded video, if I saw the same things happening in the live video. So for instance, if given the opportunity to shape the view, would people actually shape the view? So one thing is that I was really surprised that I was actually very happy to see that the remote surgeon would actually try to interrupt or give some instruction and say, can you move it a little bit down here? So that was reaffirming sort of the hypothesis that we had, that in some way, shape, or form, if you give the opportunity to the remote surgeon to shape the view, that they will do it. And it also showed, though, that they would try to find the opportunity at the right times to shape the view, though. So they didn't want to interrupt the surgery when it wasn't necessary. Oftentimes, we had a really good example of a surgeon sort of drawing on the screen very at the bottom of the view, referring to a structure that was half not in the view, in the camera capture. And the reason that he was doing that is he didn't really want to interrupt the surgeon to ask him to move the camera, but he needed to refer to the structure and say, well, you will be going down here. And that's what we called making do, that there is still this need to not have too much control over this workspace that is technically the local surgeon's workspace, that the remote surgeon will try to make do with the view as much as they can, but they will interrupt when they see, for instance, something dangerous happening. Obviously, they're like, nope, stop, you got to stop right now. Or if they really need the view to change, they'll say, I need you to move a little bit more to the left, and then we can see the structure better, for instance. Or can you zoom in a little bit, was another one that they would say, I can't quite see it. A lot of these findings highlighted the fact that there is a desire to shape the view by the remote surgeon. And now it opens up, what do those tools really look like for that remote surgeon? So this is where I go back to the CSTW literature, and I'm really actually inspired now, as we've been working on building our own telemedicine system for this, me and my colleague Ignacio Avellino, who's now at the Sorbonne in Paris. We've been building a system that allows for the remote surgeon to actually shape a view in their own personal space, whether or not that's actually the opportunity to zoom in the view themselves, or turn it slightly to have a slightly different orientation, or even make telestrations on the view. And then if they desire, and at the right moment in the surgery, to say, I want to share my view with you. And so that's where we're going right now, to give that opportunity to not always have to shape the view right at the moment of the surgery and for everybody at the same time, but allow for that personal and then shared space, which is a very CSTW finding from the past.
That's really very interesting. So I'm curious how you think, how would this translate into some other domains? So clearly you're working with highly specialized people who also are willing to be trained, right?
Yeah.
That's part of their job. But then how about me using HoloLens and telling someone to do something in their home or on their computer where I'm not a professional user, I perhaps didn't even get training or would actively resist reading the manual? And what are your thoughts on that?
Yeah, absolutely. So the HoloLens, yeah, we're doing work with that right now. It's an excellent opportunity to continue to look at what this idea of shaping the view, whatever environment that might be. Although we're looking at it again very much in telemedicine. So my colleagues at UMBC, Anita Comlori and Andrea Kleinsmith and myself, we've been working a lot with emergency medical technicians, so first responders, and the education of first responders and sort of the additional support that they might need in the field. So HoloLens was one of those things where I was like, I'm totally going to take advantage of these videos that Microsoft's been putting out, where you've got, the electrician, technician, or what may you have, and look at this within the emergency system. And there's a couple motivations for that. So first of all, it's definitely training. There's a wide variety of EMS, anywhere from like an EMTB to a paramedic who came from a 4-year degree, et cetera, who may be out in the field. And that varying level of experience, first of all, lends itself to exactly what we're thinking about with telementoring. You learn a skill in a simulation, but then there's a point where you may be faced with a very specific situation in the field, and you just need somebody to look over your shoulder or just weigh in on the situation. Oftentimes, EMTs have their phones. This is something that's been going on for quite a while in a lot of medical areas. So we've been thinking a lot about how can you use something like the HoloLens or some other AR environment to hold it over the patient. Let's say it's a tablet, and be able to have that sort of two-way conversation and have somebody who's sort of sitting in a control room is what we imagine, being able to weigh in on different cases of those that are in the field. And that is both instruction and training. So that's what's really interesting about telementoring is you really are living in that little fine line in between the two, where you're trying to give somebody some specific in the moment instructions, while at the same time understanding that they're learning at about that particular case, and that hopefully that learning grows over time. And so this is the reason why I'm very lucky to be at UMBC. We have an amazing emergency health services department who actually trains, they have their own simulation center and actually trains paramedics. They're one of the few four-year degrees in the United States. And we've been working very closely with them to think about how this is an additional education, even after a paramedic leaves their, the safety of the university and the simulation center. But then there's also the need to transform medicine in a way. We saw this with the COVID crisis. We've been talking about this with the EMS folks that we've been in contact with for a while, that the medical system is strained, at least in the United States. There's usually not enough hospital beds. Oftentimes EMTs drive from hospital to hospital, just finding one emergency room who can take a patient. This is a real problem. And then of course we've got patients who live very far away from a hospital. So one of the things that we've been working with them that's expanded sort of this telementoring work to teleconsulting is how do you again have sort of a person who can be on the call to weigh in on the more complex cases, so we can provide care in the field as opposed to always having to be hospital based, by empowering actually even emergency medical services in the field beyond what maybe they were even 10, 20 years ago. It actually supports a greater health system, both with regards to making sure that people are able to get the care they need at the moment that they need it without the additional cost of a hospital visit. But also the way that I see it is it allows for greater opportunities for people to get into medicine as a career. So for instance, historically, those from more marginalized communities have gone into the medical system through first getting their EMT license, running with an ambulance corps, and then doing night school for, say, nursing or something along those lines, and then continuing on in the medical field. Wow, you got a banana. I'm very happy for you. So I think this is one of those things where the lessons that we learned about shaping the view and making sure that people are able to sort of see and understand the world the same way in order to collaborate continues into emergency medicine. And even though it's a very different type of view that they're looking at, it's not, for instance, the laparoscopic view that I've been working on for the past 5 years.
So that's, yeah, fascinating. So I have a couple more questions, and I see that some of the questions are already coming in the chat. So one thing I wanted to ask you is this also the topic of your future of work NSF grant? So
yes.
Was that the synopsis of that?
Yeah.
That just came in, right? That's maybe a year.
You know, it's really interesting. So this is just my side story on that. So we wrote this proposal, you know, last fall of, what is that, 19 into January of 20. And as I was writing the proposal, I was thinking of all the other stories that I hear from EMTs, you know, the heroin crisis that was in the US, and about how really ambulance does not need to be taking them to the emergency room, that the EMTs need to be able to support people in the moment and then take them to a treatment facility, for instance. And also just being able to address somebody who's having a heart condition or diabetes care in the home without having to always take them straight into the emergency room. And this is very important also for older adults, where you kind of don't want to always have to take them to the hospital. Hospitals are not exactly the cleanest, most healthy places to be taking somebody. And so there was a lot of that talk. And as I was writing that, I'm reading all these articles about this COVID crisis starting to loom. And And I just wrote this one sentence, at the beginning of the proposal. I was like, we've got these health crises going on, and I listed the ones that I just mentioned. And, the growing COVID pandemic, we submitted the proposal on a Monday, and by Friday, my university was closed down.
Wow.
So it's one of those things where I was like, I've never been so prescient in my life as I was at that one moment. But I think what's really been interesting is we've been, since interviewing, my colleagues and I interviewing emergency first responders, and they've all said the same thing. They said, we cannot continue working the way we're working. First of all, they're burnt down on many levels. But there's also this need to really move towards a telemedicine and a supportive and a more networked medicine framework. And that's why actually we submitted to the future of work, because I really like that call, that it's not just thinking about how do you build a technology, but how this changes the workforce, how this changes what work even looks like. And within medicine, that has to change. One of the biggest problems with medicine that I always tell my students or anybody who wants to listen is that it's very resource intensive. It is people and equipment. Those are two of the most expensive things. And to be moving people and equipment around, there's a reason why we're in this situation right now. It's just untenable. So we have to be thinking about, how do we move the information around? Those are bits and bytes that we can easily move. And then the bigger question in telemedicine is, what is the information that needs to be moved around? Because as soon as you say, okay, we could just move the information, people are like, let's just move it all around. And we know that doesn't work. We have to then be thoughtful about what is the information and at what moment needs to be moved around. So that's a lot of where I've been going with my own work. And you can see it even with the shaping of the view. We were very specific about, we could do every video in the world for surgical telementoring, but what's the actually most important part of surgical telemetry? What is that information that they really do need to share with each other in order to make the decisions that they need to make?
And so that ties in really well with your 2021 upcoming Chi paper, right? Which is about stroke. And again, that's really neat. So what's the information that you need to move around to help stroke patients in their home?
So that was a work that we started about almost 2 years ago. I was approached by a stroke neurosurgeon who led a rehabilitation, one of the best rehabilitation systems at the University of Maryland, Baltimore, here in Baltimore medical system. And he said, I want to be able to help people in their homes. I have patients that are like driving an hour just for their rehab. I need to be able to help people in their homes. Can we build a telerehabilitation system? I said, that's really interesting. It's a new direction and area. So my graduate student, Ade Akinsiku, really was interested in this topic. Things that he did is, like any good HCI student, he went to see, how do rehab appointments currently run? How does the rehab specialist currently sit with their patient and help them in a face-to-face environment? And Ade has a background in electrical engineering. So we were definitely thinking, we're going to censor the crap out of this, right? Like, we had all these ideas about thinking about, like, what sensors are most important. And we always had this eye on being able to help the marginalized folks. Stroke overwhelmingly affects those that are low income and Black. The statistics are very high, and also rural Americans. So we were always thinking very much about the telerehabilitation for marginalized populations. What we didn't realize until he started interviewing all of the nurses and the rehab specialists is that it's not about the movement at all. Rehabilitation is, you would think, it sounds like it should be about the movement, but when you're really sitting there and listening to what information the rehab specialists are gathering, they're asking questions like, what are your comorbidities? How is your diabetes going at the same time? How are you feeling? What's the mood? What's your home life looking? Are you stable now in an apartment? Are you living with your family? Are you all alone? Are you in like a 6th floor walk up, or you have an elevator? Are you walking in a neighborhood that's safe? We live here in Baltimore, for instance. So do you feel that you could go out and go for a walk? There's all this other information that they're trying to collect. And then when the patient does their exercises, they kind of turn away. They're like, okay, do 10 of those. And then they write these notes about all of this experiential information, all of this context that explains how are they faring? Are they on the path to being able to manage their health, or is it likely that they're going to have a relapse because everything else is out of control? It doesn't matter that they're able to just do like 10 bicep curls over here. Everything else is a mess. And so we were really struck by the fact that when we think about the information, and if you look at the general where these telerehabilitation systems have been going, it's always about the sensors and how do we get the sensor data, and which cool connect can we use, or let's strap on a sensor onto the arm. And I'm not saying those things are not important for at-home exercises, but that's not the primary or the only information that a rehab specialist wants to know about their patient. And so that was really a shock to us. And that's what the Kai paper that'll be coming out for 2021 really talks about, is all these different indications about the most important thing they want to know is how is their patient faring? Are they going to be back in the hospital, or can they handle the exercises that they're giving them so far with everything else that's going on in their lives?
Thank you, Helena. This is kind of fascinating and so timely. I know that we have one question from Chris, and then I have a couple of questions. And others, if you have any questions, feel free to type them in the chat. Chris, let's start with your question.
Yeah, I almost feel ashamed. I'm going to go back to the very basic eye movements from this really important bigger picture aspects that you've been talking about now towards the end. But this came in earlier when you were talking about the telementoring. So I was wondering, I was thinking about the situation and how our eye gaze works, that sometimes we're really focused, and for surgery, of course, that's necessary. And sometimes something pops up in periphery and we can't help but look and be distracted. And I was trying to work out sort of the logic of how would this work with the remote person, because the remote person cannot be distracted by what's in periphery because they don't see it. But at the same time, if that person looks over, then they lost where they were looking. So I was wondering, is the remote person in some sense more concentrated looking, or are they distracted? Have you seen any of those trade-offs sort of with how they handle the concentrated viewing, because that's of course necessary for a lot of the parts of the surgery?
Yeah, that is actually a very, very important point. And we're actually hoping to look at that more closely with the HoloLens. We started to do with building our own HoloLens application is to have a sticky canvas for that exact reason. The remote surgeon or the remote consultant is focusing on an area, and they're maybe even working on that area. And then for any reason, whether or not it's a distraction or you've got two bleeding, gushing things going on at the same time, you have somebody turn their head and then you lose your work. And that is definitely one of those things that as we were playing with it, we said, ooh, that is absolutely going to be a problem. So this idea again of I've decided this is my personal space that I'm going to work on. And we did find an amazing, I'll get you the paper, an amazing demo that we had found at another, I want to say it was a WISC demo, where it was very much about being able to sort of move your phone around in an augmented reality, and that the remote user was able to sort of work on a sticky area, and then when the phone comes back over, it melds it again and it goes back to being the live view. And that's kind of the work that I think we need to start thinking about, exactly for that exact reason. When we talk about the real world, people are moving, they may be moving apart and working on different areas, coordinated, and then come back and be collaborative again. And being able to seamlessly be able to do that is definitely the future of system development in my mind.
Right, and there's also this balance, because you also gave the example where the remote surgeon said, well, why don't you look more to the right, or have you looked to this? So there's that fine balance between you have your sticky environment, and sounds like a very interesting data set. I'm envy. Nice one.
We have more than enough data. We're happy to share.
So I can't stop myself from going back to the big question here of scalability, right? We have a remote expert that could attend one surgery or could attend to one patient with rehabilitation, but perhaps with the help of AI could monitor multiple at the same time. So I'm wondering kind of what are your thoughts about integrating AI, especially we talked about data collection with the stroke patients. I could imagine that some of it could be a bot, right? That start a conversation, imagining how you go to the doctor today, kind of a physical, and you have a nurse that collecting a lot of the data before the doctor is coming so that the doctor can kind of see more patients. So what is your vision about integrating AI and remote expertise?
Yeah, absolutely. I think a little over a year ago, I would have been like, you don't have to put AI in everything. This is not one of those. And watching what has happened over the past year with the COVID crisis and the conversations that I've had with practitioners, you're absolutely right. And we need to be thinking about what that might look like. I like the bot idea. Some of the surgeons that I was talking to recently about telementoring, they're still very excited about the future, but they said, we just can't scale up to that one-to-one. A surgeon puts away 2 hours of their time just to watch somebody else's surgery. It's just never going to happen in the current health environment that we're at, especially in the US with how we sort of have this payer model. However, if we're able to use AI to be able to weigh in on, say, the things that we normally see, especially for a particular type of surgery, the typical view, these are things that probably computer vision could easily identify. And then be able to sort of ping the remote surgeon to pop in for the most important aspects, that's the way to best use the people, again, moving the people, this finite resource around. Same with the EMS. So one of the things that I'm always imagining, and my colleagues and I have spent a lot of time also looking at stress, indicators of stress and cognitive load, and how we can recognize when that's occurring. One of the things that we've thought about is if we had the mechanism, you imagine, I'm sitting here and I'm watching like 10 view, or I have the input to 10 views, that I get an indication of when there is a stress or cognitive overload. And that is what I then can say, hey, do you need me right now? How you doing over there? Or, assuming that the person might not even be aware of their own stress level rising or their own cognitive overload. So being able to support that one-to-many model is definitely the point where we need to start thinking about how AI can support this.
So do you have any thoughts of how some of the, for example, shared view negotiation techniques could be used to inform this kind of negotiation between a human and AI agent?
That's really interesting. That's really interesting because it's absolutely going to happen. And I think that, and it can also make the decision as to what could be the potential view that needs to be passed on.
Yeah.
Which might not be the current view. It may be something along those lines of being able to monitor the periphery and see the other situations that are arising and need to be addressed as soon as possible and bring in the expert. Yeah, that is absolutely a crossover I had not thought about. This is why I have these conversations.
I think that this is such an exciting topic because we're really kind of, I think, at the eve of a revolution of where we're going between kind of human remote collaboration as well as teams that will have human AI, perhaps multiple humans, multiple AI agents that kind of work together. And I could see the end user being experts on one hand, like surgeon, but I could also see the experts have to guide and empower people that are not expert. For example, kind of how can we work with COVID-19 patients to monitor themselves, right? And when do we need the AI and when do we need the human to intervene when something goes wrong? COVID-19 could be stable for a while until it's not, and then the intervention is required very quickly.
Exactly, right. Because you have that whole problem where you're feeling bad, then you start feeling good again, and then you all of a sudden you spike again. Yeah, that is a very good use of something like a telemedicine structure. The hospital at home is kind of the direction that that many in the medical field have been talking about, and how we need to be able to support people being able to stay in their homes and being able to be cared for. And this requires both a team of people being able to go around, because sometimes you need people to be in the room, literally. But that doesn't always mean that that team of people can't also be a virtual agent who's supporting the person in the home as well. It would be fantastic to see that future. And the one thing I would love to highlight here is the only reason we're able to really talk about this is because of COVID-19. Because up until a year ago, policy, insurance models for paying for telemedicine, liability models in terms of hospital insurance, all of these things were getting in the way. This wasn't as much a technology or a people problem as it was more of a systemic issue that we couldn't move forward. This is the time to be trying to help move healthcare forward in these innovative ways, thoughtfully, of course. But before we slide back too far in the old models that I just don't think were allowing us to be able to scale up healthcare.
Thank you, Helena. This was really fun.
Thank you.
What I'd like to do now is to wrap up the formal part, and then we can move on to a more relaxed part. So before we stop the recording, next week we'll have MC Strafel, and she's going to be discussing the embodied perspective of the future of work. So again, thank you very much, Helena. And everybody, please stay on for a little bit of a social time.
You're very welcome. Thank you, everyone.